TopMedTalk.
Well, hello and welcome to TopMedTalk. We're here for the Society for Obstetric Anesthesia and Perinatology, or SOAP, in Denver, Colorado. I'm Desiree Chappell, co-editor-in-chief and host of TopMedTalk, and joining me today is former editor-in-chief of TopMedTalk, Monty Mythen. Hello, Monty.
Good to be here, Desiree. Thank you for having me back.
Yeah.
And I stepped down because I'm now work for Edwards Lifesciences since August last year. Still emeritus prof at UCL and adjunct at Duke. But it's great that everyone allows me to sit in occasionally when it's appropriate.
Yeah, and it is appropriate. We're here for the first time at the SOAP meeting in Denver, and it is absolutely fantastic.
Brilliant meeting. I've known about it for years, but it's the first time I've attended one.
Yeah, I heard it's been around for about 55 years. I think next year they're celebrating that. We did. I verified that earlier. And it is an absolutely fantastic meeting. The people here, the vibe, it is all like so positive. And I feel like there were some really good conversations in the plenaries. Everything's been great.
It's a great structure of a meeting as well.
It is.
There's plenty of networking time. Single auditorium plenaries as far as you can gather, but then lots of breaks out. I think the posters presentations get time, which is good. They get audiences, they get questions, which is well done.
Very cool.
Yeah, there's lots of them, lots of free papers.
Yeah. We just want to say thank you to SOAP and the organization for having us here and providing a space here in the exhibit hall so we can do our thing and meet some really great people. So thank you very much, and thank you to all of our sponsors who keep TopMedTalk free and open access to the world. Monty, I'm very excited to introduce our next guest because he's kind of one of the reasons why we're here at SOAP. It's Dr. Pervez Sultan. Hello, Howard.
Hello, and thank you for having me.
So this is your first time on.
Yeah, delighted to be here.
Yeah, absolutely. So we've met in the past through different SOAP people and different meetings, but you and Monty have a little bit more of a history here.
We go back a little bit.
Yeah.
So we should probably start a little bit. Where's that accent from?
I'm a Manchester boy from Northwest England. So if you're from Manchester, then you have to like football.
Yeah.
Soccer, that is. You can't say football in America. You have to
you can say football.
Okay,
it's fine.
but yeah.
You now have to ask which one.
Oh, yeah.
Oh, Man City or Man United?
I'm the one that's not doing very well these days, so Man U.
Oh, yeah. It's okay.
Honestly, why don't you just change? And you can't do that either.
So you're from Manchester?
Yes.
Manchester.
So,
born and brought up in Manchester, and then I went to university in Edinburgh, capital of Scotland, which is a great place to be a student, actually. It's a very nice place that you can walk from one end of town to the other, and a great place just to be in medicine, actually. I met some great mentors there. And then I moved down to London for my senior residency. And that's where I had the pleasure of meeting Monty. I got interested in research during my fellowship year, which I did at Stanford under Brendan Cavallo, who's now my division chief. That kind of ignited my passion for research. I went back, and then under Monty's supervision, I did a research degree looking at perioperative immune function. And actually, during that time, my original idea was to take a lot of the things that I was looking at in the non-obstetric setting, like biomarkers for worse outcomes post-operations, and I wanted to bring that into obstetrics. Yeah. But I kind of got scuppered along the way because I realized that there weren't any good outcome measures for post-childbirth. And that's kind of how I ended up going from immunology into social science.
So we should clarify a little bit of the history there. Because when you say supervised by me...
I was like, which part of that?
Your real supervisor, just in case he is the wonderful Professor Dr. Gareth
Ackland, yeah. So I worked with Gareth in Mervyn Singer's lab at UCL. So I just
retired. I don't know if you picked that up.
Oh, I didn't know that.
Yeah, Mervyn's just, well, I think all the parties are his retirement.
Yeah. Might be for something else.
They might have too many cakes at home.
No, I mean, we were very lucky to have 3 people that were so supportive and encouraging for research. And traditionally, anesthesia hasn't attracted many PhDs and MD researchers in the UK, but a lot of it was focused in London. So that was one of the reasons why I wanted to do my senior training there.
Yeah, fantastic. And so now, where are you now?
So then I took my 5 years into my attending job in London. I kind of was always thinking about my lovely time in Stanford, and the timing seemed right to go back. And I have lots of fond memories in London, but I think from a research track that I wanted to pursue, I think it was the right decision for me.
Yeah.
Just for people listening who are interested in potentially changing countries, and so I worked in America at one stage, not unusual to do that. At times it's hard and at times it's easier. Did you hit a medium window, or so visas, green cards, but then did you have to go back to medical school? Did you?
Yeah, so good question. So a lot of it is very state dependent and also very institution dependent as well. So I can just tell you about what happens at Stanford, but to get into a position where you're likely to be there for a while, you kind of need to do your USMLE. So for the fellowship, I didn't, but the fact that I was coming back, I did have to do my USMLE, which isn't an insignificant amount of work, actually. So I had a 2-month-old at the time when I was studying, whilst juggling kind of research and a full-time job in the NHS.
And that's your medical school finals again.
Yeah.
Which I'd be fine, but medicine's moved on from since you did them.
Yeah, exactly. And also there's 3 parts to it, which are all, different amounts of work. But I'd say that step 1 is the one where you're learning about embryology and biochemistry, again, in quite a lot of detail. So that was the most challenging part. And the other parts were actually fine once that one was...
But you passed.
I passed.
You're here.
Yeah.
Hurrah.
Thankfully, I was told that I just had to pass. So looking at anesthesiology in the States now is like one of the top 5 desirable residencies. So the scores for USMLE are needing to be really high. And, looking at the quality of residents that I teach at Stanford, it's unbelievable. We have very, very smart cookies there. So glad to be approaching US medicine from the attending side.
Yeah.
Trying to get
into do it now.
Absolutely.
Great. So you've been, let's talk about SOAP for a little bit.
Yeah.
So you've been affiliated with the organization for a while. Tell us about your journey here.
So I first attended SOAP the year before I started fellowship. So that was 2009. And that was in Washington, the first meeting. And the first thing that struck me was how friendly people are. And I think it's maybe something to do with being an obstetric.
Well, you have to deal with awake patients a lot.
Awake patients that usually aren't sedated and are also probably amongst the most anxious patients in the hospital. So I think communication skills are a give me in our specialty. So it tends to attract people that are quite nice and genuine and quite warm-hearted. Yeah. And I picked up on that straight away. And actually, since 2009, I haven't missed a single SOAP meeting. And it's like one of my highlights of the year. And it just feels like a family here. And everyone is super supportive. We've got some amazing quality researchers in our field. And I'm happy to say that the numbers of NIH-funded researchers in the society is on a really good upward trajectory. And one of my mentors is Brian Bateman, who's also my chair. Yeah. And he's just done phenomenal work looking at, drug effects on and safety during pregnancy and abnormalities. And some of these papers are getting published in the New England Journal, JAMA, and really impressive things. And that, one thing that I do want to say is that the specialty and research within our specialty has changed so much in the past 10 to 20 years. And in some ways, I think obstetric anesthesia used to get a bit of a bad rap in terms of what dose of bupivacaine are you going to put in the spinal. And those were important questions, but I think we've moved on to bigger questions that are impacting maternal and neonatal health in a bigger way in the peripartum period. And I think some of the outcomes research that we're looking at is really focusing on the fact that we have this rising US maternal mortality rate, and the majority of deaths are happening in the postpartum period, and the majority of those deaths are happening after the patient's discharged from hospital. And I don't know if you have children, but I'm like a very evidence-driven guy. So after our children, I came home and I was like, okay, what's going to happen? What's a normal recovery?
Yeah.
And there are 140 million women that deliver babies around the world, and we don't know what a normal recovery is.
Isn't that fascinating?
So to repackage that, having babies in the well-resourced countries has got safer and safer over the centuries.
So it has, but in the US, maternal mortality rate is actually on an upward trend.
There are 2 components to that, because the people who are having babies seem to be, many of them, at greater risk as well. There's 2 components to that.
Yeah. There's definitely a population that is becoming a higher risk population. And we're almost victims of our own success because there's more grown-ups with congenital heart disease where patients were previously told, sorry, but you shouldn't get pregnant. Whereas now we are, correctly so, offering the chance for people to have families, which is great. But also that comes at an acknowledged increased risk as well. But I think within the whole of the United States, it's bucking the trend compared to Europe, for example, which is pretty static, if not dropping maternal mortality rates. But there are some states where we have success stories, for example, California, and a lot of the work that they've done with the CMQCC, which is the Californian Maternal Quality Care Commission, they've learned lots of lessons from the UK, actually. So they have like their maternal mortality review boards, they review deaths, lessons that you can learn from it. There's lots of QI, and then they introduce toolkits for sepsis, for example. And we're in the process of trying to develop a toolkit for enhanced recovery as well.
Oh, fantastic.
So yeah, but the mortality it's a complex picture in the US. And one of the talks that I give is actually about maternal mortality rates in general. What we want is for no country in the world to have a maternal mortality rate greater than 70 per 100,000 live births. And that's the United Nations Sustainable Development Goals target for 2030. And in some countries like India, you've got a success story because they've actually, reduced their maternal mortality by a factor of 4 in the past 20 years. But even within India, you have these geographical disparities where some of the northern states have 4 times that recommended mortality, whereas the southern states actually have maternal mortality better than some of the states within the United States. So there's a huge disparity geographically and racial disparities as well within the United States and every country in the world. So there's so much work to be done about access to healthcare, health literacy, really addressing the fact that geographical and racial disparities, we've talked about it for 20 years, but now we really need public health targeted interventions. And I think there is funding coming into this area now.
I just finished reading Bruce Bickard's book on safer surgery for Africa, the professor from University of Cape Town. We've interviewed him on TopMedTalk before. It's very hard to believe how relatively simple and affordable the solutions seem to be.
Yeah. I mean, like just looking at postpartum hemorrhage, this is one of the leading causes of maternal mortality around the world. And if you look at the causes of deaths, like 4 out of 10 people that are dying from that don't receive prophylactic uterotonics. So in the US or anywhere in the Western world, you deliver a baby through C-section and the first thing you get is oxytocin.
Yeah. And can translate that for a broader audience?
So uterine atony or failure to contract of the uterus is the commonest cause of postpartum hemorrhage. And the best way to prevent that is we usually administer a prophylactic dose of oxytocin intravenously, and 9 times out of 10, that's all you need. But for many of the deaths that happen in the developing world, those drugs aren't available, and there's also inadequate training of when to give it in terms of education, and there's often not the skilled staff to administer those drugs. And the other thing that is brought to mind is the quality of drugs is very variable due to inconsistent legislation surrounding drug manufacturing quality, transportation of drugs in hot countries. So often these aren't heat-stable drugs, so you need to be refrigerating them. And then if you have a power cut and your fridge goes out, then your drug may lose its efficacy as well. So, there's so much like simple things that we can do. And one thing that's coming to light is maybe introducing heat-stable drugs like carbetocin. That's an alternative to oxytocin, which is not currently FDA approved in the US, but in those countries, it would actually be very useful to introduce.
Yeah.
The other thing I'm still trying to get my head around is that I read the explanation from Bruce, and we're going to interview him again about it recently, is the price to have equity of healthcare access for less well-resourced countries comes down to about $100 per person per year, which I thought, okay, that's very challenging. And then he went on to explain the fact that it's actually the country is up on the deal. So the provision of the health, anyway, I'm going back onto the African. So we'll interview Bruce against that soon, but similar challenges are taking place at the moment in the United States of America.
Yeah, absolutely. So my area of research interest is postpartum recovery, and it's probably the most underexplored area that we have. So the first thing that I did in this journey of trying to get to the bottom of what is postpartum recovery, I started to interview people qualitatively. So I interviewed experts in the field, like obstetricians, maternal fetal medicine specialists, midwives, nurses, and patients themselves. And I just said, what is postpartum recovery? What is recovery after childbirth? And in total, I had like 24 hours worth of amazing qualitative interviews. We generated like word cloud analyses, and we actually published this in the British Journal of Obstetrics and Gynecology. And we actually developed this conceptual framework which comprehensively describes what recovery is. And we identified 13 different domains. Now, a lot of them are just really obvious, like sleep, fatigue, breastfeeding, postpartum medical complications, infant health, maternal and neonatal bonding, things like that. And obviously psychiatric causes of morbidity go into that as well. So for the first time, we've actually identified these domains. Once we identified the domains, I did a massive scoping review. I'm never going to do anything like this again. We had a massive team, but we reviewed about 8,000 titles and abstracts. And this was published in JAMA Network a few years ago. And for the first time, we actually had a list of 201 validated measures that have been looking at different aspects of recovery. So clearly with 201 measures, there was no consensus on what the best measure is. So then we went into deep dives into each one of these domains. So we were like, okay, what is the best measure of postpartum pain? What is the best measure of postpartum depression? What is the best measure of postpartum sleep? And the way that you can actually identify what the best measure is that there's this Dutch group called the COSMIN group, and they've developed guidelines of how to do a systematic review like this. So they measure different things like psychometric properties of an instrument, such as validity, does it measure what it's supposed to measure? Reliability, is it reproducible? And responsiveness, can it detect changes over time? So we did these reviews, and now we've actually got a list of 13 different ideal measures. And in the best paper competition just yesterday, we presented a new measure that we developed for outpatient recovery. So in the same way that when you have a baby, the baby has their height, weight tracked on a chronological basis, we can now do this for maternal postpartum recovery with this new measure that we've developed. So we've got 4 domains that we've clumped things into. So the first is physical recovery. So we can start tracking this up to 3 months postpartum. And then the next one is mental and emotional health. And then the next one after that is sleep and fatigue. And the next one is maternal motherhood experience. So really exciting work. So now that we have this measure, we're going to start to try and get population data. And if we identify patients in the lowest centiles of scores, now we can start to develop targeted interventions and really try and change trajectories of postpartum recovery. And if we know like the majority of deaths are happening in the postpartum period, we can really start to try and impact that directly with our work.
Desiree, those 4 domains, they resonate?
Oh, well, yeah, as a mom. I mean, it's someone who's gone through childbirth and had recovery at home and where it wasn't fantastic. And I laughed on the sleep part because, is there a mom that actually gets sleep?
But this is the thing. It's really interesting. So my NIH grant that I got is to specifically develop a promise measure for postpartum sleep. So a survey instrument which comprehensively we can screen patients with. And everyone has the same experience of, oh, I've just had a baby, of course I'm not going to sleep. But actually, sleep disorders, when you prospectively screen people, are highly prevalent. Approximately 2/3 of women have a sleep disorder in the postpartum period. But when we looked at California state data, only 2% of people were being diagnosed with it. So there is a huge disconnect. Because people are just brushing it under the carpet. And then when we did a deeper dive on the relationship between sleep disorders and depression, it's really, really, really overlapping. So 1/3 of the patients with sleep disorders had postpartum depression, and suicide is the leading cause of maternal mortality. So why shouldn't we be referring patients that aren't sleeping or offering kind of baby care so people can get dedicated sleep, especially for patients that have twin pregnancies or single moms that haven't got the social support network.
Or high-risk moms that are already coming in with depressive tendencies or history of. I mean, those would be ones that you absolutely need to support. And it is just so hard. You don't expect to sleep. And all of us, I mean, all of the traits that are the ones that you struggle with the most are all amplified when you have no sleep and then you have this baby. And so having support.
One of the biggest cultural differences that I found between the UK and the US was the attitudes and provision of maternity care and paternity care. My sister had twins in the UK 7 months ago. She's still on maternity leave, and that's not unusual in the UK. Many people have a year off. First 6 months is full pay. Second 6 months is kind of statutory pay in the NHS at least. And my brother-in-law actually works for a Swedish company, and he's only just gone back to work now, having been on full pay. Whereas I'm seeing our residents who are working 80-hour weeks with babies that are 2 months old. It's really difficult. And actually thinking about the effect that this is having on our residents, I don't know how they do it. It's really, really difficult.
Well, it's the healthcare industry as a whole. I mean, it's not. It's just the U.S. culture. I mean, you go back to work 6 weeks if you can. I mean, there are people who have to go back earlier, 8 weeks if you have a C-section. I mean, you're still very sleep deprived. I mean, all those things that you mentioned are things that are not resolved in that time period.
Outstanding work. No surprises from Pervez. Practically, how do you capture how do you measure it?
It's just a 47-item questionnaire, and we've been doing it through RedCap. So we just text a link to the patient.
So Desiree's at home, and she's a week out. Well, talk us through that one.
So for our study, we did it at 4 time points. So we did it at the inpatient postpartum time point when they're in the hospital. And then the next one was at 2 weeks, and then 6 weeks, and then 12 weeks. And we simply send a little text message or an email to the patient when they're at home with a link to a RedCap kind of, it's like a SurveyMonkey equivalent where you can just collect survey data. And there's 47 questions, and each question is scored out of 4. And it gives you a really good idea of how someone is recovering. And we actually found that you could summate the total scores as well. So we looked at 6 weeks because this is a really important time point in the US. It's when the obstetric follow-up clinic happens, and it's also when insurance cuts out. So in our data, we actually found that patients hadn't fully recovered to their baseline. And also they were exhibiting and demonstrating that patients who had had a baby before are scoring better than patients who are first-time mums, which isn't surprising, but it's important because we're not currently offering them any different care. The other thing is patients that have had a baby that needed a NICU admission are doing much worse at 6 weeks. So this isn't, even though they're out of the NICU, like there's still ongoing effects. And similarly, if you've had a prolonged inpatient hospitalization after childbirth, then you're still doing worse at 6 weeks. So we need to identify these high-risk groups and offer them some other intervention. And my big vision for this whole thing, and I'd hope that we can get this funded at some point, is, but at 2 weeks, we need to have a multidisciplinary clinic where the patient comes in. How are you doing from a wound point of view? Right, great. You're going to see the sleep specialist. You're going to see the psychologist. We're going to get your baby check at the same time. And we're going to get a lactation consultant. Because in the first 2 weeks, one of the biggest causes of anxiety is actually
nursing
and breastfeeding. And it's a huge cause of concern that's not currently being adequately addressed. And once again, I keep making comparisons to the UK, but at week 1, after 7 days, you have a district nurse that comes to you
visits
and looks at your wound and does a depression screen and things like that. And I think we're really missing an opportunity to identify people that are not doing well. And it's interesting when you actually speak to the obstetricians about this, and I say, why don't you see them at week 2? And they were being honest, and they said, look, there's so much going on, we would be inundated. Now, that's not a reason not to see someone. In fact, that's a reason to see someone. We need a whole mindset change, and there needs to be a change in provision of primary healthcare for postpartum. And it's a whole new specialty in itself, actually.
And engagement with the questionnaire. So a few questions there. There's the bias of the enthusiasm to engage.
Yeah.
And what one does if there's no engagement.
Yeah. And that's been a problem with the postpartum studies, because the $1 million question is, are the people that are not responding doing worse, or is it because they're doing so great? And actually, we did a comparison of responders versus non-responders. They were pretty similar in terms of demographics, which is nice to see. And actually, we had probably more multips, so patients that already had babies that weren't responding, but they tended to be doing better at the 6-week time period anyway. Interestingly, Asian patients had higher response rates as well, and patients that had lower education status had worse response rates. So that's interesting. One thing that we try and do to increase engagement, I don't know if you've heard of the My Health app. Stanford is an example of something that has this. So when I broke my ankle last year, before I came to my follow-up appointment, I had a ping of, are you ready to check in for your appointment tomorrow? Before you check in, how's your mood? How's your physical activity? There's some screening questions.
Yeah.
So I would love to see our new measure to go into that before the 6-week outpatient, just to make it a seamless link of, we're going to screen you just before you see your obstetrician. And the obstetricians say to themselves, they get 10 to 15 minutes with these patients. So that's enough maybe to talk about how the wound is doing and how they're doing physically, and maybe even to go over some of the stressful things that might have happened around the time of childbirth. They haven't got time to go into everything. So by having the screening questionnaire, it can ping up and have red flags of, hey, you may need to have a deeper dive into depression or breastfeeding or sleep.
We don't usually do things in the National Health Service unless either by design or default we've worked out that we're up on the deal. So it's cost effective to do the extra screening because it's preventative, et cetera, et cetera. So who do you need to talk to in the US? Is it the insurers? Is it, where do you go with that?
It's a good question. So now that we've developed this measure, I'm accessing a few different things. So we're currently working with an industry partner that has a online kind of peer support kind of platform. And they're very interested in the postpartum space. So they're hoping to use the STORK measure. It's the Stanford Obstetric Recovery Checklist, STORK, as part of this. And for each of the domains, they'll have a mentor that's kind of had a poor recovery in that area, but has lived to tell the tale.
Yeah.
And so I think that will be a nice way of engaging people, like they have with the NCT groups. So people who are expecting babies have a peer support group of similar gestational age. So they know that there's going to be 5 or 10 mothers that are going through similar things at the same time. And that's really effective, and probably even more effective than seeing your doctor if you've not got a condition that needs hospital admission. Yeah. So I think things like that would be really, really useful. And hopefully we're going to leverage the SOAP research network at some point to get really big data and really establish with good confidence intervals what a normal recovery should look like.
Yeah, I'm just blown away. It's fantastic work, and it resonates with me, of course, as a mom. One thing you said, it's going to be a whole specialty and we really need to focus in on this. I feel like obstetrics and maternal health, we focused a lot on lactation. That was whenever I had babies, 10, 12 years ago, whenever it was. It was just kind of starting, and then maybe the pendulum swung, everybody has to nurse, and it's the best thing, and if you're not, you're failing. And that was lots of pressure during that time. I feel like maybe we're kind of finding an area of reason now. But, we focused a lot on that, so it got a lot of attention. So maybe, we need to see this in other spaces, because I saw a lactation consultant pretty early on. Yeah. And if you had somebody who was not just focused on lactation, but really talking to you, maybe not as much as you're on your wound, hey, how you doing, depending on what it was, but more around the psychosocial peace and sleep, I think that would be phenomenal.
I think you're right about the feeling of I'm not managing to breastfeed and therefore I'm a failure. And that's why you're getting so much relationship with that and anxiety. We've talked a lot about psychiatric conditions, and I think that's where a lot of work needs to be focused on. And everyone focuses on depression, which is obviously really, really important, but the forgotten things are anxiety and actually also post-traumatic stress disorder.
100%.
So we're just about to start a study looking at prevalence of post-traumatic stress disorder after childbirth, and early studies show that about a third of people that deliver describe it as a traumatic event, which is shocking. That's large numbers. And actually, even speaking from personal experience, with our first, my wife had a massive hemorrhage a month after delivery. So she ended up needing an emergency general anesthetic. We've both got a little bit of PTSD from that situation. Yeah. But the thing is that even when you're having a normal delivery, think of how long a normal labor is.
Oh my God,
have a period
it's dramatic.
You've got a period where you're in pain. The anesthesiologist is supposed to get to you within 30 minutes, but that's 30 minutes of being in severe pain, right? And that's kind of a quality metric. The other thing is, think about the other things that are happening in your labor. You know, you have a sudden drop in the fetal heart rate. Someone pulls the emergency cord buzzer, everyone's running in the room, and then it recovers. Oh, don't worry, everything's fine. Some people, that was just, that was an immediate threat to my life and the baby's life.
Yeah. And everybody acted like it was horrible, but now everybody's gone.
Yeah, exactly.
That happened to me. And I heard the fetal heart rate drop before anybody walked in the room. And I told my husband, there are a bunch of people that are running in this room right now.
And I bet you, when you think about it now, your heart rate goes up.
Totally. I'm having anxiety right now.
Yeah. These experiences don't leave us, even if you're a medic and you know what's going on. They're really stressful events. Anyway, I'm going to be fascinated to see what post-traumatic stress prevalence really is. And the interesting thing is, sometimes you have the late presenters, so you may actually screen negative in hospital, but once you've had time for the dust to settle and you start thinking back like we're talking now, you may actually screen positive, and we've got an amazing psychiatrist at Stanford, Deborah Kaysen, who's actually NIH funded in PTSD. So we're going to be looking to kind of get a grant together for screening, and then patients that screen positive for PTSD to have these like cognitive behavioral therapy options and see what works. And that's one thing that we're really focusing on in this SOAP meeting is intraoperative breakthrough pain. There is no other operation where you would not be sedated, where you'd have pain and many times you just carry on whilst treating the pain rather than converting straight to general anesthetic. So we've really had a big push this meeting to try and really put this message out of intraoperative breakthrough pain is a real problem, and it should be treated aggressively, and general anesthesia should not be withheld from patients if warranted.
So that's a pendulum that's swung too far, because I keep saying in these podcasts, it's a long time since I was in there, but you wouldn't hesitate to convert to a GA before we were very, very pro epidurals as spinal.
Yeah. I think so. And I think also there's a lot of focus in anesthesia, not just obstetric anesthesia, about quality metrics. And we often are presenting quality metrics in our institutions without the same statistical rigor.
Yes.
So your GA rate, and the SOAP Centre of Excellence criteria says that your GA rate should not be more than 5%. But it's an expert opinion. Why 5%? It's not really backed by much, level 1 evidence. And then you run the risk of having a culture where we should avoid general anesthetic rather than let's do what's right for this patient. And if we're at 10%, then actually maybe that's appropriate because the intraoperative breakthrough pain was being treated actually quite aggressively. And in the same way that epidural rates of replacement during labor, if you have a high replacement rate, that might be a good thing because it means you're actually checking in on your patients and identifying the labor epidurals that aren't working. So we've just actually had an opinion piece accepted for publication in Anesthesia and Analgesia, really asking about quality metrics and how we should be reviewing them in our QI meetings. And I think we really need to be thinking about whether things are statistically significantly different, but also clinically. And if there are changes in rates, then could this be accounted for by other factors, institutional factors? For example, staffing, equipment changes. There's so many things that go into these things.
So when you say with intraoperative pain and having that, I remember I haven't done OB forever, but I remember whenever I would do it, if that happened, it is very scary for the patient. As the provider in the room, you're just like, what do I do? This, and you just start throwing stuff at it, and it's a seemingly uncontrolled situation unless you decide to do a general. Have you looked at PTSD and trauma and things like that related to that, post-operatively and post?
So in the Best Paper Award yesterday, basically with the SOAP Research Network, we had 11 centers that contributed data. It was like a snapshot audit where everyone was followed up after their C-section, whether it was an emergency or an elective case. And there was a number of about 2,600 patients, so good numbers, and 25% of the patients that experienced pain described it as distressing, and it was a traumatic experience. So that really is more than we were expecting.
Yeah,
so I think this is opening, the door to, this is preliminary data for us having a kind of a prospective study, which is an interventional study at this area. This kind of all started so we published this big systematic review a couple of years ago, looking just at elective C-section with adequately dosed neuraxial anesthesia. And surprisingly, we found that 15% of patients had inadequate levels of anesthesia. There are 1 million sections happening. That's perfect. So that's a lot. And that's elective. And we know that the rates are higher for emergency because epidural top-up is not as good as a spinal or a CSE. So we're just in the infancy of this work. And I would say this is actually one of the most important unanswered questions in our specialty.
No.
Any sense of where the trade-off is from the mum's perspective, the pain versus going off to sleep?
Yeah, I think we need to engage more in shared decision-making and adequate counselling. So the consent process needs to maybe include the fact that you may have pain, but normally you don't need to go to sleep with it because we can adequately manage it.
Have they stopped that one then? That one used to be normal in the last century.
Well, I think people often say, you may feel pressure, you may feel tugging, but nothing should be painful. Whereas actually, it's different to say, 15% of people do feel pain.
Yeah.
It's just how it's...
And if it's too bad, we can put you off to...
Exactly. That's usually said.
Okay.
But I think it's the 15% that's not being...
That's important.
I think so.
And I think the thing with pain too, it's now, as we're learning more, it's so different. So like pressure, tugging, that pulling sensation, for some people, they interpret that as painful.
Yeah.
And
the other thing that's really important is the quality of block assessment preoperatively. That's something that's getting a lot of discussion in our society at the moment. There's a lot of variability in what's done, but the more modalities you test, the better. Motor, sensory, using different modalities of touch, things like that.
People still doing by poke the ice cubes and surely there's some sort of monitor. Edwards doesn't have one. There's no stickers that go up here and no, that's not out.
And motor block is the other one, the Bromage score that's classically done. So
it's still ice cubes and freezy strays.
Most people use light touch and a bit of cold and maybe something sharp. And then the surgeon does a forceps test before we start.
Just to be clear, what I've worked out from this meeting is I'm available next week if you need.
Yeah, exactly. Oh my gosh. Yeah. Well, Professor, we could continue to talk.
It's been a pleasure.
One reassuring point we should make before we go, because, lack of sleep associated with children and also being a clinician on call from home. The good news is it gets better just around the time when you get to an age where you can't sleep properly anymore.
Yeah.
And also when you come to one of these conferences, then you don't get any sleep.
No, it's so true. We were just talking about that. But we contributed to that, to being in a high altitude.
Yes, it must be the altitude.
That's why I can't sleep. Pervez, the amazing work. It has been wonderful to hear about all the work that you're doing and the great work that's being done here in the SOAP organization. We hope we can catch up again and hear more about it.
Thank you for having me. Till next time.
Yeah.
Congratulations on your career. We should have said you're on board of directors.
Oh, yeah.
Have you been the president at some
time? No, not yet.
Oh, you're
I'm a bit young.
Yeah, that's awesome. Well, thank you so much. And hopefully we can have some more conversations about this. And, you can always find some other great conversations here from SOAP this year, 2024. On TopMedTalk at TopMedTalk.com.
And I want to just say thanks to Nancy. He wrote my reference letter to get my job at Stanford. And I just got promoted a month ago. So congratulations. Thank you so much.
Yeah, I don't know if we said what your exact title is.
I'm a professor of of anesthesiology at Stanford and an honorary professor at UCL as well.
Fantastic. Right. I know. Awesome. Yeah, Monty says he knows how to pick them. That's great. Well, and like I said, thank you for listening to TopMedTalk. You can find this and other great conversations at TopMedTalk.com, social media, X, LinkedIn, Facebook. We are there, YouTube. If you find us on YouTube, give us a thumbs up, subscribe, check out all of our other content. Lots of good stuff there. And thank you so much for listening. I hope you learned a lot today. This is a good one to share out with friends. I think a lot of people can learn a lot from this conversation. So thanks so much. Cheers.
Thanks again.
Yeah.
Bye.
TopMedTalk.
Thanks for downloading TopMedTalk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.